Hi, my name's Gal Delani. I'm a pediatric cardiologist with Nemours Children's Hospital, and I'm here today to talk with you about hypertension in children. In 2017, the American Academy of Pediatrics updated their clinical practice guidelines for the screening and management of high blood pressure in children and adolescents. And we wanted to go over how to implement those within your clinical practice to enhance the care for your patients. Our normal blood pressures are determined based on our age, sex, and height. Previously, a diagnosis of prehypertension has been replaced with elevated blood pressure. And for children over 13, they're considered adults, so we'll use all the adult standard blood pressures for that. If we look at the chart below, normal blood pressures for children should be less than the 90th percentile for their age, sex, and height. An elevated blood pressure will be a blood pressure greater than the 90th percentile but less than the 95th percentile. Stage 1 hypertension will be greater than the 95th percentile. And stage 2 hypertension will be greater than the 95th percentile plus 12 millimeters of mercury. When we look at normals for those children who are greater than 13 and for adults, a normal blood pressure should be less than 120 for systolic blood pressure. And elevated blood pressure would be between greater than 120 but less than 129. Stage 1 hypertension will be between 130 and 139, and stage 2 hypertension will be greater than 140 millimeters of mercury for systolic blood pressure. When we look at using these blood pressure normals within a busy office practice, one has to have kind of a normal value to think about for an age range. For any child under a year of age, a systolic blood pressure should be less than 100. For children 10 and less, less than 110. And for teenagers, should be less than 120. This is a chart from the American Heart Association that summarizes this and may be useful for your office practice to remind your medical assistants and your nurses when they're taking blood pressures where they fall into range for patients that are over 13 or on adult size. Our key points when we're looking at blood pressure screening is number one, annual blood pressures should be done in children greater than 3 years of age. There should also be checks at every encounter for patients that are deemed high risk. So those that have obesity, those that are on medications known to elevate the blood pressure, those that have kidney disease or renal disorders, those that have had congenital heart disease or a repair of coarctation of the aorta, or those that have diabetes. When we look at high-risk medications that can elevate the blood pressure, Table 8 covers many of these medications. And there are also certain patients that require blood pressure screening less than age 3. So those would include patients that have a history of prematurity, those with congenital heart disease, those with kidney issues, and those with a history of solid organ transplants or on medications that are known to elevate the blood pressure. When we look at managing our blood pressures within an office-based setting, when we have a child that comes in and has an elevated blood pressure, what do we do for that child? So number one is we want to make sure anytime a blood pressure is checked, the child is nice and relaxed and calm. And then if that blood pressure is elevated, then what we typically do is we would see the child back in 6 months for a repeat blood pressure. At that time, we would also check our upper and lower extremity blood pressures to ensure that there's no evidence of coarctation. If that was still elevated, then we would see the child back in another 6 months, so basically a year from the very first encounter, and repeat the blood pressure. If that is still elevated, then we would schedule an ambulatory blood pressure monitor and a diagnostic workup to follow. When we look at our ambulatory blood pressure monitors, they're very useful technology to be able to detect true hypertension in children. So it gives us a full assessment of the blood pressures over a 24-hour period, so we can look at the child in their normal environment when they're at rest and are calm around their family and friends throughout a 24-hour day. And ambulatory blood pressure monitors are very good at also detecting white coat hypertension for that. One thing to keep in mind is that home blood pressure monitors just done by the family or the child should not be used to make a definitive diagnosis of hypertension. An ambulatory blood pressure monitor is much more accurate. For those patients that are greater than 6 years of age and have hypertension, they don't typically require an extensive evaluation for secondary causes of hypertension. If they've had a positive history of hypertension, are overweight or obese, or have physical exam findings that are not associated with secondary forms of hypertension with that. Things that one may want to think about would be the perinatal history. Are they premature or not? Their nutritional history. What is their salt intake? What is their level of obesity and how healthy is their diet? What's their physical activity history? So have they been getting more than 60 minutes of exercise on a daily basis or not? Psychosocial history and family history. So have they had a parent that also has a history of essential hypertension or not? If one has one parent with essential hypertension, you would expect the child to have about a 7-fold increase in the risk of developing essential hypertension. If both parents have a history of essential hypertension, then that would increase to almost a 14-fold risk for the child. When we look at screening for secondary hypertension, Table 14 goes through that, and going through those key points within the history and the physical are important to keep in mind for the different disorders. If patients have elevated blood pressures that persist, we do go down the route of a diagnostic evaluation. Some key items to think about during that diagnostic evaluation is that electrocardiograms are no longer recommended for screening for end organ dysfunction within the heart. In order to determine left ventricular hypertrophy, it's recommended that a child undergo an echocardiogram, but does not need an associated electrocardiogram with that. Other things to think about are a renal ultrasound with a Doppler to assess for the possibility of renal artery stenosis. And in children that are over age 8 or obese, if there is renal artery stenosis or there's a high suspicion of that, a CT scan or an MRI may be warranted with that. When we look at our initial evaluation of a child with hypertension, the things that we want to do in all patients are a urinalysis, a chemistry panel, a lipid profile, and a renal ultrasound with that. If the child is obese, then we may also want to add a hemoglobin A1C, liver enzymes to look for fatty liver infiltrate, our fasting lipid panel, our fasting glucose, thyroid panel, drug screen, sleep study, and complete blood count. So once we make a diagnosis of an elevated blood pressure or hypertension, one of the most important things a provider can do is to counsel the family. And not only counsel the patient, but counsel the entire family, because many times other people within the family will also have essential hypertension as well. So we want them to be able to maintain a healthy weight with a BMI of less than 25. We want them to eat healthier and reduce their complex sugars, fructose, high fructose corn syrup, extra carbohydrates. We want them to reduce their sodium intake, and we want them to get active and receive about 60 minutes of physical activity daily or more. One thing that can help families is the DASH diet, and that's listed for you at the bottom with increased portions of fruits and vegetables, low-fat milk products, whole grains, and increased amounts of fish and poultry for their diet. For patients who have persistent hypertension, many of them may need pharmacologic therapy. When we look at medications that children tend to respond to, ACE inhibitors and angiotensin receptor blockers are some of the more common ones used in the pediatric population that have very good safety thresholds for that. Ambulatory blood pressure monitors may also be used in long-term follow-up of patients with hypertension to be able to assess their medical management. In summary, I wanted to share with you the 2017 guidelines for managing hypertension in children. And through your efforts in terms of taking care of kids, cardiovascular disease really starts in childhood and progresses into adulthood. So the difference that you can make in these children may help them throughout their entire lifetime with that. And we hope that by getting good control of hypertension in childhood, that we can save lives as they get into adulthood and reduce cardiovascular disease in the future. I thank you for the time to talk today and hope you found this helpful.